Hello, I'm Sheria Robinson-Lane, faculty at the University of Michigan School of Nursing, as well as affiliate faculty with the Michigan Alzheimer's Disease Research Center. I'm really delighted to share with you today the work that I completed as a project with the Michigan Center for Urban African American Aging Research. This project focused on adaptive coping and Black family caregivers of adults with dementia. Again, this study was funded by the Michigan Center for Urban African American Aging Research. Currently, we know that there are more than 41 million caregivers for adults over the age of 50. And within this demographic, dementia family caregiving is associated with the most negative health outcomes of all the different types of caregiving that adults can provide for older adults. Some of the sorts of care assistance that are provided to older adults include activities that will fall under what we consider instrumental activities of daily living, like being able to use the telephone, shopping, paying bills, preparing meals, completing one's own laundry, taking medications, as well as what we consider activities of daily living or dressing and grooming and feeding oneself. One of the things that we know is that when it comes to Black dementia family caregivers, that within this list of the types of assistance that are provided, Black family caregivers are much more likely to provide high intensity care. So when we look at this instrumental list of activities of daily living, they are more likely to be performing at least 6 things on this list. And with the activities of daily living, they're more likely to be performing at least 3 of these activities. And so the care that Black dementia family caregivers provide compared to other caregivers is much more intensive. The length of time that they're caring for their loved ones tends to be a much longer period of time. And the caregivers themselves have an increased likelihood of having poor health, being at risk for a future dementia-related diagnosis, as well as, unfortunately, experiencing a premature death related to the poor health outcomes and some of these other factors here. Also, in Black dementia family caregivers, they have an increased risk for Alzheimer's disease and other sorts of cognitive impairments. And dementia-related diagnoses, similar to the persons that they may be caring for, often takes place at a later stage, which means that by the time that individuals are able to receive support or even identify what sorts of supports are available to them, it's much later within the disease trajectory of the person that they're caring for, where they're more likely to be experiencing more significant symptoms of cognitive impairment and more likely to result in emergency room visits as a result of trying to figure out what's going on with their loved one. There's a lot of income variances among these caregivers that affect the care options that are available to them, which is why many of these adults end up caring for their loved ones at home and oftentimes without added support, such as receiving respite care or home care services. These caregiver responsibilities, as well as normal sorts of variances in socioeconomic status, affect the income of the household. As well as these caregivers tend to have a bit lower education than other similar sorts of caregivers. All of these things can increase the comorbidities that these caregivers experience, and again, increase their overall disease burden, which is why we see increased morbidity within and mortality within this group. Finally, Black caregivers are less likely to use support services. Part of this is related to geographical constraints of being able to get to where support programs were when they were in person. Now we're seeing with COVID-19 that many more of these programs are being offered virtually, which is assisting in some ways with individuals. Many of the programs used to have health system membership requirements. So in order to be a part of the program or even to know that the program existed, you had to be a part of a particular hospital system or receiving care at a particular doctor's office or going to a specific senior center. And then there were disease state specific, meaning that if the person didn't have an exact Alzheimer's dementia in the past, it was the access to programs were limited. And we know that this has also changed to some extent now, which is very helpful in particular for Black adults that are experiencing Alzheimer's disease and other forms of dementia, because Black older adults are most likely to have mixed forms of dementia, where they may have vascular dementia and a combination of Alzheimer's disease and not just a singular incidence of Alzheimer's disease. The other issue is that many of the support programs are not culturally responsive in design, which simply stated, they're just not very interested to diverse participants, and they don't engage individuals in a way that wants to, where they are interested in continuing to participate in these programs, because they don't hit upon some of the values and culturally specific needs of caregivers. And so one of the things that I was interested in thinking about caregivers and how they continue to be resilient regardless of many of these things that were not in their favor, is really asking the question of what factors contribute to adaptation, or how these caregivers are able to continue to remain resilient despite the stress and perhaps burden of caregiving, and particularly within a cultural group in which it is not culturally acceptable in many instances to use terminology such as stress or burden when referring to caregiving responsibilities. So the goal of this work was to identify a culturally responsive approach to caregiver support that promoted adaptive coping and optimizes health. And this work is based on a couple of premises. First, that the shared values, beliefs, and customs that create communities, meaning communities of color, and specifically communities of Black adults, extend to ways of coping. And second, that when we are able to identify and reinforce the adaptive coping strategies that communities prefer to use, so the things that folks are using to help them to survive and manage stress effectively, when we promote those, then we create strength-based programs that support both the community as well as the individual, meaning the community of caregivers as well as the individual caregiver that needs support. So the model that we're working with is based upon a nursing model, the Roy adaptation model, which is a stress and coping model. We're looking at the stressor being the dementia care needs that the caregiver is attempting to manage. And what we are evaluating is the coping processes, or the different ways that caregivers are managing the stress of coping, and then how their coping results in adaptation to caregiving. The moderator here is the caregiver's physical health, which is a bit different from some of the other models of stress and coping amongst caregivers, where physical health outcomes sort of sit on the other end of the model. So we eventually would like to evaluate whether or not physical health is a moderator and affects the relationship between dementia care needs and caregiver coping. And then we also want to consider whether or not the caregiver's mental health, whether or not they're having experiences of depression, anxiety, and those sorts of things, are mediators to coping and how they adapt to caregiving. So for this particular study, we wanted to recruit a sample of 30 Black caregivers who had or were currently caring for persons with a dementia-related diagnosis. The inclusion criteria for this pilot study that we wanted to test our ability to administer this survey was limited to 30 participants in the southeastern Michigan area, because we were delivering these surveys in person at this time and collecting the results in person. We did recruitment by using participant registries through both the Michigan Alzheimer's Disease Center as well as the Michigan Center for Urban African American Aging Research. We went through sororities and fraternities, went to church health ministries. That was actually one of the best ways of recruiting. We probably recruited the vast majority of our participants by using the church health ministries. community education events that were sponsored by the research centers above. And then also, we ended up, not for this particular study actually, but for our current work, we did some Facebook advertising. For this particular study, we posted survey flyers on Facebook, but we didn't use the Facebook advertising tools. What we found is that the survey took about 45 minutes for our participants to complete, which was pretty outstanding considering we have about 200 different data points that we were collecting with this work. And part of the reason that the survey completion time was so quick is that because we had prior interactions with caregivers prior to going to their home and working with them to complete the survey, we were able to talk through what was included in the survey, the sorts of questions that we were able to add, building rapport, and some of the things that would often increase visit length. The initial findings that we have, again, is that the survey took about 45 minutes. There was a really low participant burden for the people that were able to complete it. Most people that wanted to discuss their experiences when we were in person, they really hadn't had the opportunity to talk with other people about what it was like to be a caregiver and to have someone to just listen to them without judgment. And we found that recruitment was really successful by using both the minority participant registries as well as the local community education events. The results of the study are that we found the average age of the participant was 64 with a range of 41 to 79. In our current work, we brought that age range up a bit, and we're only working with participants who are 55 and older, who are caregivers. The sorts of care assistance that were provided by these caregivers were about 75% were providing care for more than 2 years. They were caring most often for a parent or a spouse, and the vast majority of our caregivers were women. Some of the health concerns that we identified is that there was a significant issue with weight amongst the group. The vast majority of the group were either overweight, obese, or morbidly obese. And consequently, the primary health conditions that we saw were hypertension and diabetes. Interestingly, one of the things that we don't see very often reported amongst caregiving populations is the high incidence of pain amongst this group, where more than half of the caregivers reported moderate to severe daily pain, which on a 0 to 10 pain scale means that people were reporting pain of at least 5 or an average of 5 in addition to their caregiving responsibilities, which is really significant when you think about people that are needing to support individuals physically in the care that they are delivering. The adaptive coping strategies that we were able to identify that the caregivers really identified with and that they were using to sort of navigate the caregiving experience was really drawn upon a sense of spirituality, drawn upon their past experiences in providing care either for children or other family members, talking with other people that had had similar sorts of experiences, and then trying to find as much information as possible were the typical ways in which they dealt with stressful situations. Adaptive coping was significantly associated with positive physical health amongst the caregivers, positive mental health, more perceived social support, as well as self-efficacy for being able to control upsetting thoughts about their care recipient. So all of this work resulted in being able to move forward. This research, that since we found it feasible, we were actually able to move forward with getting a funded K01, and we are currently rolling out the larger version of this survey, the National Caregiver Survey, where we anticipate getting a sample of 385. We currently have about 96 participants recruited, so recruitment is going really fantastic, where we've been using a variety of the recruitment methods that we spoke about, as well as doing some specific Facebook ads and other sorts of implicit ads. So we're really excited to keep this work going. I'd like to thank our team, my co-investigator, Mark Sang, my students that I work with, and my mentors that are worked with me on this project as well as on my K, Dr. Giordani, Titler, and Danav. And of course, shout out to Lula Brown, my grandmother, who died of Alzheimer's disease at the age of 98. Thank you for listening.